And if you need a copy of the slides, you can email me at bhendrix, HENDRIX, at usetinc.org, and I can send those out to you. And lastly, we'll have a survey, a quick survey at the end of this that'll be posted in the chat. If you'll fill that out, it would be very helpful for us. And we'll go ahead and start with Taloa giving introductions.
Good morning, everyone. So today we have our updates for the Nashville area given by Imani instead of Christy. And then we'll go to Dr. Jorge Mera for his updates. And we're going to get updates from Dr. Brown about testing. So a lot of updates today. Imani, would you like me to pull your slides up?
Okay, I'm sorry, should I start?
No, Imani, are you with us?
Yes, I'm here.
Okay.
Did you guys have my slides? I sent them over, but...
Yes, Taloa will pull those up.
Okay. Alrighty, thank you, Taloa. I will now provide just a brief overview of the Nashville area COVID-19 epidemiology. This will just consist of providing an update on the numbers we are seeing as far as COVID-19 testing in the USET region goes. And so we last gave an update on July 9th. And since then, we have seen an increase in the total number of COVID-19 tests administered. That increased from 11,730 to 13,027. We also saw an overall increase in the total number of positive COVID-19 cases, which increased from 1,235 to 1,337. And then we also saw an increase in the total number of negative COVID-19 cases, which increased from 79 the last time we reported 9,812 to 10,617. Next slide, please. So this graph was taken from our USET aggregate report, which will be sent out today as planned. It just depicts the cumulative incident rate, which is calculated from state data rather than tribal data. And we give you a breakdown of the cumulative incident rate for COVID-19 cases by USET counties, by state, and then compared to the overall United States rate. And so as of today, we see that the USET county rate is at 154.27 cases per 10,000, while the USET states rate is 134.59 cases per 10,000, and then compared to the overall United States rate, which is at 106.14 cases per 10,000. So as you can see, our region does have a higher cumulative incident rate than that of the United States as a whole, and this has been the case with what we have reported in the past as well. Next slide, please. And then just lastly, as a reminder, we are offering the USET TC COVID-19 surveillance tool to assist tribal nations with tracking their COVID-19 cases. And so if you are interested in getting access to a RedCap account or just have general questions, you can please direct those to usetepi@usetinc.org. Thank you. And that is all I have.
Thank you, Imani. We'll move on to Dr. Mira.
Okay. Good morning, everyone. So what I'm going to present today is basically two things. A little bit of at the end of update on treatment. There's been in the last week, we've incorporated dexamethasone as part of the treatment. I want to comment on that. But, you know, and as you all know, we have increases of COVID, you know, across the country. Some states hit more hard than others. And I've been getting a lot of questions of if we don't have a vaccine and the only way to, you know, deal with this pandemic is to develop immunity, and the only way to develop immunity, quote unquote, would be to get infected. Why just not release everything and avoid the economic problems that the pandemic is having and just get it over with? So that's been like a pretty constant theme and questions I've been getting. And, you know, I have my personal answer, but I was, you know, let me find some data that supports what I would tell people who are asking me why we shouldn't do this. And I found this very interesting modeling study. The authors are from Europe, and I'll share it with you. So the premise of the study is that non-pharmacological interventions, or NPIs, have been the mainstay for controlling the pandemic until we get a vaccine or until we get an oral antiviral that's effective. But we know that, you know, many of the health systems and the countries where these occur suffer adverse economic consequences. And in some situations, you know, it is plausible that the economic consequence could even be worse than the consequence of the pandemic itself. So many countries, and we live in one, heterogeneously, because each state that dictates what they do, are considering lifting, you know, non-pharmacological interventions. And many of our states actually have done that. So what these authors look is the intervention of what they call dynamic non-pharmacological interventions, which is intervals of relaxed social distancing and other measures, alternating with you know, going back to quote unquote normal, which is not strictly normal, may have an impact, and this would be probably better for the economy of those regions. But what it's not known is what is the ideal frequency and duration of intermittent social relaxation, and what is the ideal break when interventions can be temporarily relaxed. So this is what they looked at. And they did a multivariate prediction model. It was very well done because they chose 16 countries. Those countries were classified into high, low, and medium economic regions in these categories. And they looked at local data for each country, meaning what is the age distribution on that population, what is their ICU bed capacity, and they took the assumptions on incubation periods of the disease, percentage people who get admitted to the ICU, were obtained from the data that we know from the pandemic so far. So they modeled what would happen if in each country, if there was no intervention, if you intervene with cycles of mitigation followed by relaxation, or suppression followed by relaxation. And I will define what these two mean. So a mitigation cycle is a combination of measures that include social distancing, hygiene rules, basically hand washing and disinfection in workplaces, contact tracing, they call this case-based isolation, And then shielding of vulnerable groups, like people at a very high risk, they should not be asked to, go to work and do those things. School closures, and including restriction of large public events. That's a mitigation cycle. And a suppression cycle is a more aggressive. It's all the above, but it includes a complete lockdown of a city, a county, or a country. And you alternate these mitigations or suppression cycles with a relaxation period. Now, relaxation means that you go back to contact tracing and shielding the vulnerable groups, but all the rest is open. Like if you had to shut down your school, you open it again. If you were applying a very strict social distancing, you relax that a little bit. So you just go back to contact tracing and shielding of vulnerable groups. And on the suppression cycle, the relaxation periods is exactly the same. And then they also did a third thing, which was, okay, let's not cycle it. Let's just do continuous suppression, like continuous lockdown. Well, what would that look like? So I'll send Brian the manuscript in case someone wants to read it in more detail, because they give the data for 16 countries. US is not included. I'm not sure why they did not include the US. Maybe it was very difficult because here we live like it's one country, but it seems like we have 50 different countries within one country. So I took the example of Australia, which is a developed country. I would say very comparable to the US, if not better in many aspects, especially health-wise, public health-wise. So this is what would happen in Australia. Let me walk you through the graph. The x-axis is the number of days since the pandemic starts, and the y-axis is the number of people requiring ICU, which is very interesting. They didn't put mortality or number of cases infected. It's people that need an ICU bed, because whatever intervention you do, you need to make sure that you take care of the very sick, because that's the intervention you need to mitigate mortality to some degree. So the pink line is, excuse me, no intervention whatsoever. So you can see that it peaks at around 70,000 ICU beds required, and then it comes down. And the dotted line here is the number of ICU beds in Australia. They have 2,200 ICU beds. So you can see very clearly that it gets to a point that there will be about 70,000 people without an ICU bed. If you intervene doing mitigation, which is the beige line, and this is the R naught, how much you're expected to decrease, you can see this type of activity. Remember, one thing I forgot to mention, the gray columns are the intervention, and the white is the relaxation. So here you produce an intervention, and everything comes down, your requirement for ICU beds, then you relax and it goes up, then you implement the intervention and it comes down, and so on and so forth. You still see that with that mitigation intervention, you still have quite a bit of people above your ICU bed capacity. But if you do the blue line, which is the suppression, and basically it's almost like a lockdown. You can see that you lock down for 50 days, you relax for 30 days, you lock down for 50 days, you relax for 30 days, so on and so forth. So you get this type of curve, but it's always below your ICU capacity. So I just put and on the original manuscript, you will see this plotted for 16 different countries. And it's very interesting to observe what the results are. Now here I plotted I put the graph of Afghanistan just to show you what are the differences between countries. And you can maybe even argue that in the United States, what are the differences between states? So this is the capacity for ICU bed is the first main difference. And in Afghanistan, you have 100 ICU bed capacity. These are true numbers compared to Australia that you have 2,200 ICU bed capacity. When you look at the curves in Afghanistan, they're very similar except for the blue one that seems a little bit different than this blue. And the reason is because they took the ages of the population. So countries that have the majority of the population as a young population, they probably will require less ICU beds than a country like a developed country that has older population which means sicker population also, unfortunately. And people who, and remember that one of the drivers for more morbidity and mortality is age. So if you have a country with younger population, your ICU bed requirements are going to be a little bit less, and the impact of the pandemic will be a little bit less. But anyways, what is very similar between both of them, that only lockdown really achieves to be under their ICU bed capacity. Now, of course, if you could increase the ICU bed capacity to 1,000, you'd be fairly well in Afghanistan just with this intervention of mitigation, not needing suppression. So then they looked at this graph here is without relaxation. This is like complete no stop lockdown. You lock down and you don't stop. You do it for a year or whatever it takes. It's interesting that if you do not do an intervention at all, the pink is still without any intervention. If you don't do any intervention, the pandemic peaks, decreases, and it's probably over in about 200 days. It's about 8 months. And it kills a lot of people because if in Australia, if you only have 2,200 beds, it is estimated that if you don't do anything, they have 197,000 deaths. Now, if you do mitigation, which is the baseline, you are still going to, but this is complete lockdown. Without relaxation, you bring down the deaths to about 9,000. And if you do a full lockdown, the number of beds of deaths is about 4,900. But the interesting thing is that if you do a complete lockdown, you get rid of the pandemic much sooner than if you let it take its course. Now, this may take, depending on the country, a full lockdown for maybe 4 months. Nobody has really done that. China kind of did it a little bit in their own way. Now, there's no guarantee that after you are in this phase here, if there's a couple of cases going on, you might have a rebound of the pandemic or a second wave. But I thought this was very interesting, that if we really paid attention to the science, maybe our interventions will be more rational. So what they conclude is that dynamic cycles of 50 days of mitigation followed by 30 days of relaxation reduce transmission. However, it was unsuccessful in lowering ICU hospitalizations below manageable limits. Now, when you do suppression, basically lockdown for 50 days and relax for 30 days, that kept the ICU demand below capacity in most countries, if not all. So significant number of new infections and deaths, especially in resource-poor countries, would be averted if these dynamic suppressions were kept in place for about an 18-month period. So one thing I forgot to tell you, this needs to be kept up for about 18 months if you're trying to relax and mitigate for it to have an effect. I'm sorry. Intermittent, okay, so what they did with suppression, that really took care of business. Intermittent reductions to bring the R0 below 1 through combination of suppression interventions and relaxation can be an effective strategy for pandemic control. But putting a schedule that is like permanent, it might be complete suppression might not be sustainable, especially in low-income countries. That's asking like a country like Peru, you have to lock down for 5 or 6 months completely. That would probably tear the economy down and all the other services related to the economy. So the final thing is efficient implementation of dynamic suppression interventions, therefore confirms a pragmatic option to prevent critical care overload and deaths, gain time to develop preventive and clinical measures, and reduce the economic hardship globally. So, okay, that's that manuscript that I will send to you. Another thing, excuse me, another thing that I wanted to mention is there was a paper that was released, a manuscript that was released saying that hydroxychloroquine and azithromycin could be beneficial for hospitalized patients. And this really created some mayhem because then you had all the people saying, see, I told you this drug works, et cetera, et cetera. But the problem is this, when we look at the study, it's a retrospective, non-randomized, non-blinded design. It was carried out here in the United States in the Henry Ford institution. I think it's in Detroit. There was no information of the duration of symptoms prior to hospitalization, which that could be important. But this is the biggest bias of this study. The combination of hydroxychloroquine and azithromycin was reserved for selected patients with severe COVID-19 and with minimal cardiac risk factors. So basically what this means is you came into the hospital and you had to have COVID, of course, and be sick enough to require the treatment. But if you had any cardiac issues, you would not be eligible for treatment. And since this was not a randomized controlled study, you could think that maybe the patients with a lot of other comorbidities that are prone to death were not even getting the treatment. And so you could have had more mortality in the control group just because they were sicker patients. Also, when you looked at the control group, there were more patients that were older and that were hypoxic and that had comorbidities. And then even the authors say at the end, our results require further confirmation and require prospective randomized controlled trials to regularly evaluate the safety and the efficacy of this drug. It's not that the authors did not point out their own the problems with the study. They did. And then the pros were it was a large cohort. They had high rates of death, of comorbidities and death. So it's like due to the number of patients and the mortality, you could come out with significant numbers and results. And they did do a multivariate analysis to tease out confounding variables. But I still think that this is the main problem with this study. And then we do have randomized control studies that have said this doesn't work. So the NIH halted the clinical trials of this drug because on their randomized control study, the drug did not pose any benefits, and it did pose some hazards. And we also have a control study that it doesn't work for prophylaxis. Maybe not the best designed control study, but and this was randomized, but it's as good as it gets. And unless you produce one that tells you that hydroxychloroquine can help, I don't think we should use it. And the guidelines do not recommend their use. So when you're looking at the timing of treatment, it's important to know that different type of interventions will work at different stages of the disease. Here we have a patient that starts on day 0, getting exposed, then they have fever, then they become hypoxic, and then they get the cytokine storm, develop distress syndrome, and then they either die or recover. So antivirals and convalescent plasma probably work best really as early as possible. But then immune modulators probably have their best shot right before or at the cytokine storm. So in summary of this is the IDSA, Infectious Disease Society of America guidelines for treatment. There's only 2 drugs that are treatments that are recommended. One is remdesivir, which is the antiviral from Gilead. We know that there's not good data that it decreases mortality yet. I mean, it seems that it could, but it does decrease duration of symptoms and hospitalization. And I'll show you some data on dexamethasone now. Then all the rest are in the context of clinical trials, except for convalescent plasma, that due to the fact that it's hard to get in a clinical trial, the FDA has allowed us to use it outside of a clinical trial. But all the rest are recommended only in the context of clinical trials. So the NIH, so these are the IDSA guidelines, and these are the NIH guidelines, and they recommend the same thing. Remdesivir is recommended as treatment, and dexamethasone is now recommended as treatment. But all the rest come under categories that are either not recommended or only in the setting of a clinical trial for all the rest of the interventions. And here, convalescent plasma and immune globulins, there's insufficient data to recommend for again. So I think if you have access to them, you could use them, but probably not, except for convalescent plasma. So dexamethasone is a corticosteroid, and we use it for a lot of inflammatory conditions, autoimmune diseases, etc. You can use it IV or orally, but it's not, it's not holy water. It can cause a lot of problems. including cardiovascular side effects, bone side effects, hormonal problems. So you really need to make sure that you're using them where they have a proven efficacy, or you're just getting the side effects, which could be very frequent and also severe. So this study came from the recovery trial that's been held in Great Britain, and they randomized patients that are, initially the randomization included patients that were 18 years or older and had a clinically or laboratory confirmed SARS-CoV-2 infection. Then they took the age out in May, and they are including PEDS patients now. And this study is very interesting because you get randomized either to no additional treatment, or you get a drug, either lopinavir, ritonavir, or dexamethasone, or hydroxychloroquine, or azithromycin. And then they can also be given convalescent plasma. And finally, even if you got randomized to a drug, but your disease is progressing and you're hitting the cytokine storm, you can further be randomized to an additional treatment with an IL-6 inhibitor. They have more than 11,000 patients enrolled from 175 hospitals. And on June 8th, they had to stop recruitment on the dexamethasone arm because they had enough patients enrolled that proved that the drug was beneficial. So this is what happened. When they looked at all participants, and these were like over 6,000 people, the mortality was lower on those who received dexamethasone compared to those who were receiving usual care. It's not a big gap, but this was statistically significant. But when they looked at subpopulations, if you were on the group that was not getting oxygen, let's say you had COVID-19, you had pneumonia, but you did not require oxygen, the use of dexamethasone was not statistically significant. But when they looked at the ones that were using oxygen, or especially are on a mechanical ventilator, then that was statistically significant. So the recommendation was to use on patients with COVID-19 who are admitted in the hospital, who have a pneumonia, are hypoxic, or requiring mechanical ventilation. That's where the biggest bang for your buck you get with the dexamethasone. And the dose is 6 milligrams once a day for 10 days, IV or oral. And there are, if you don't have dexamethasone, you can use prednisone 40 milligrams or methylprednisolone 32 milligrams. This is just the same data looked in a different way. Anything to the right of this line is bad. Everything to the left of this line is good. And you can see that patients who were on oxygen, invasive mechanical ventilation, there was a benefit of using dexamethasone. And these are all the patients overall. But when you get the ones that do not have oxygen, actually there's no benefit on using dexamethasone. They also found that other secondary measures that discharged patients from the hospital within 28 days were better on the dexamethasone group. Also, the need for mechanical ventilation was lower, and of course, mortality. So this is why the NIH and the IDSA incorporated dexamethasone as part of their armamentarium as recommended drugs. And on this slide, I'm not going to go through the details, but you have the doses that you can give, and some other caveats. So finally, these are all the drugs that are still on randomized clinical trials being evaluated, the antivirals and the immune modulators. There are other studies that are using steroids at different doses and different timing. So I think we just need to wait a little bit more, and maybe we'll have some better news in the future. And there also was a report, I'll probably cover it next week, of a vaccine trial with New England Journal of Medicine that shows some promising results, but still there's a long way until this vaccine can be proved to be efficacious and marketed. That's it.
Great. Thank you so much. Do we have any questions for Dr. Mira? I see we have a couple comments in the chat box.
Okay, yes, so Harry's mentioning that the recovery trial had a hydroxychloroquine arm that showed no benefit, yes. And it is important to know that there was benefit only in patients needing oxygen. Yes, right. No benefit if you do, correct. That's what it's on the graph that it's not dexamethasone for everybody, but for those who meet those criteria. Or the other caveat that we've been using it is if the patient needs steroids for another reason. Let's say it's a COPD exacerbation or a patient with asthma. Then if they have another indication, you use it. But if they don't have another indication for steroids, you only use it in patients who are hypoxic or in a mechanical ventilation. Thank you for those comments.
Do we have any other questions for Dr. Mera? If not, we will move to Dr. Brown.
Could I, let's see,
Yeah.
I need to share my screen. Yeah. Okay. Can you hear me okay? All right, thanks. Yeah, the only reason I brought that up is a lot of you probably know that I work part-time as a hospitalist at the Cherokee Indian Hospital here in North Carolina with the Eastern Band of Cherokee. And I recently saw one of our emergency room doctors handing out dexamethasone to COVID patients who weren't very sick. They were going home. And I had to point out that the study really only showed benefit in people who were either on oxygen or on a ventilator. Yeah, thanks for the opportunity to talk to you. A lot of this will be sort of a review of a talk that I gave about 2.5 months ago on testing, but there is some new information that I wanted to share with you, especially about the Abbott ID Now. I've saved that for towards the end of the talk, but there's now quite a bit of data on the sensitivity and specificity of the test in clinical practice. So welcome to day 129 of the pandemic. If anybody cares, it's day 133 for no haircut for me. But today I'm going to just review what sensitivity and specificity really mean, what emergency use authorization by the FDA really means, review the types of tests we have to diagnose COVID-19, talk about a new antigen test that was just released recently, and then give you that information about the Abbott ID Now. And I will end with just some bottom line take-home messages. So sensitivity and specificity is a concept that confused me a lot as a student and as a practicing clinician. I always have to learn it for boards and then I kind of forget about it. But basically, if you take people that you want to know, do they have this specific disease? So let's say that we want to know, do they have COVID-19? So you test people for it, and people fall into one of 4 categories. They either have the disease and their test for it is positive, so these are the true positives in this box here. Or they have the disease and they test, they have the disease, see how confused I get? They have the disease and they test negative. So these are the false negatives. So people that have COVID-19, but their test is negative. And then there are people that don't have COVID-19, but if they test positive, these are the false positives. If they don't have COVID-19 and they test negative, these are the true negatives. So in this column are the people with disease. Those are the true positives plus the false negatives. In this column, we have people that don't have the disease. These are the true negatives plus the false positives. So sensitivity is a measure of the test's ability to find people who are sick or to detect people with a disease. So it's defined as the true positives divided by the true positives plus false negatives. So it's people that have the disease and how well the test does. There's an acronym that I like to use to help me to remember something about that, and this is SNOUT. And that is a highly sensitive test with a negative result essentially rules out disease, or with, you know, a high degree of trueness. So if you're looking at a screening test, that is, you're trying to screen a large population of people, you want to make sure that that's a highly sensitive test. In other words, it has very few false negatives. So then we look at specificity, and specificity is how well a test can detect people who are well. That is, how well it detects people who do not have the disease. And this is defined as the true negatives divided by the true negatives plus the false positives. So this is a test's measure of how well it finds the people who don't have disease. And even though this is a little bit counterintuitive, the acronym SPIN stands for a specific test, a highly specific test with a positive result actually rules in disease. So in other words, if your test has a very low rate of false positives, then you're mostly getting true negatives. So that's a highly specific test. So a highly specific test has very few false positives. So if you're using a diagnostic test, that is, you know, you have a person in front of you, you think that they have the disease. You want to have a test with high specificity in order to say whether or not they have the disease. That is, one with few false positives. So that's sensitivity and specificity in a nutshell. Now I want to shift gears a little bit and just review what FDA emergency use authorization means. So if I'm an inventor and I invent a new lab test and I want to market it in the United States, I have to get FDA approval for it. Now, FDA approval takes a long time, usually months and maybe years to get FDA approval. You have to, you know, test the test under lots of different conditions and prove that it works. But you don't have time for that during a public health emergency. So FDA rules allow, during a declared public health emergency, that they can do this thing called emergency use authorization. So it can only be issued if the Secretary of Health and Human Services has declared a public health emergency, which that is our current condition. And the EUA, the emergency use authorization, is only valid during the period of the declared emergency. So as soon as the emergency is declared to be over, the test no longer has the authorization by the FDA. But during an emergency, the FDA can authorize a test using a very quick process. And basically, they just look at whatever results the company has, do a quick risk versus benefit analysis. And if the product is determined to be most likely safe and more or less effective, then they give an emergency use authorization. All right, so laboratory tests for SARS-CoV-2, they basically fall into two different categories. There are diagnostic tests for presence of virus, and there are diagnostic tests for the presence of antibody to the virus. There are two types of tests that test for the virus. There are viral RNA tests, and there are viral antigen tests. And I'm going to talk about each of these tests now. So just to kind of review a little bit, this is a schematic of the SARS-CoV-2 viral structure. So it's a coronavirus. It gets its name from the fact that it looks like the sun. It has all these spikes coming off of it that make the corona, just like sunshine. So these spikes are a glycoprotein, and that's the way that the virus attaches to our cells. Now, in the center of the virus is the virus's genetic material. It's a positive sense single-strand RNA virus. Don't don't get all hung up on what that means, just the fact that it's an RNA virus. And the RNA is protected by what's called the nucleocapsid, or the N protein. Then it has this lipid envelope around it, which actually is good for us. It makes it very vulnerable to soap and water, alcohol, just about any cleaner disinfectant you want to use. And then it has these other proteins that are kind of stuck in the envelope, the HE protein. So you could test for maybe all of these different things, and I'm going to kind of go through that. So viral RNA tests, there are lots of names for this, and that's part of what makes all this confusing. Testing for viral RNA is usually done by a nucleic acid amplification test, which PCR, or in the case of COVID-19, reverse transcription polymerase chain reaction, RNA test, because SARS is a RNA virus. Sometimes it's called viral particle test, a viral nucleic acid test, molecular test. All of these are really just synonyms for the same thing. So how exactly does PCR work? It's, as I said, it's a reverse transcription polymerase chain reaction. That's what RT-PCR stands for. So how it works is you extract viral, well, you don't extract really, you stick a swab up somebody's nose or into their oropharynx, and hopefully the swab has virus on, well, actually, hopefully it doesn't have virus on it, but if you want to find the virus, hopefully the virus is on the swab. You put the swab into some solution, and the first thing that's done is reverse transcription to make a DNA copy, because the lab test machines actually read DNA rather than RNA. So you convert the RNA to DNA, then you heat the DNA up to unwind it. Then you put in some primer of the desired target gene that you're looking for. And then through some scientific magic, you make a bunch of copies of that desired target gene. And after multiple cycles of copying the gene, you put in a detector to see if the gene's actually present. Now, each cycle that it goes through requires heating and then cooling, which is what makes PCR take usually 2 to 8 hours to perform. So now I'll show you a picture, because I understand it a lot better if I see a picture. So up at the top here, you see the DNA copy that's been made. This is the double helix DNA. It's been made from the RNA. And you heat it up to unwind it and split it into 2 strands. Put in the primers and you make 2 copies. And then you do the same thing. You heat it up to pull those strands apart and you make some more copies. So you go from 2 copies to 4 copies to 8 copies to 16 to 32. And after you do 20 or 30 cycles of this, you have millions of copies. And then that's when the machine can actually detect that it's there. So PCR testing, what can go wrong with it? Right now, we have 108 commercially available PCR tests that have an emergency use authorization from the FDA. And this technology is actually quite reliable in the hands of experienced lab people. So why are there false negatives? Well, probably the biggest reason is sampling technique. Either, you know, the swab isn't put in the right place, or it just doesn't get any virus or enough virus on it. The other thing is transportation hazards. These specimens have to be kept cool, and after about 48 to 72 hours, they have to be kept frozen at -70 degrees centigrade. That's really, really cold. My freezer doesn't do that. You have to have a really special freezer to get it that cold. But the other thing is timing of sampling. If a person is later in the course, if they're a week into their symptoms, their viral load in their upper respiratory tract tends to be very low, and maybe too low to really get a good sample. Now there are false positives, but these are very rare actually, and usually due to lab error. Either you've misidentified the sample, it's got the wrong person's name on it, or it gets mixed up, or you contaminate the sample somehow with the virus. So, but for the most part, PCR testing, once it gets to the lab, is pretty reliable. But as we've gained experience, we found that there are actually a lot of false negatives with PCR. And this is a slide that I got from Dr. Mira. It's one, if you were on the call last week, you saw this slide. So this was a study that came out in May in the Annals of Internal Medicine. They reviewed they reviewed a whole lot of studies, but they found 7 studies that met their review criteria. And these studies were done with people mostly in which there was serial testing. So these people may have had 1 or 2 or 3 negative tests, but at some point in the course, they tested positive. And then there were also some studies that looked back at people and did antibody testing, and they tested positive with the antibody test, even though they had tested negative with PCR earlier. So what did they find? Well, they found that timing is critically important. So let me just walk you through this. Right here is where people have onset of symptoms. Back here is where people got infected. So this is where they were exposed and infected. Here's where symptoms started, which averages around 5 days after the initial infection. And then here we're going out to 14, 21 days. So what we see is the lowest false negative rate occurs right here, right after people became symptomatic. And on, I believe it was day 10, day 8 after infection, or day 3 after symptoms started, they had the lowest rate, but it was 20% false negative. Now, if you get exposed to the virus and you run out and get a test the next day, 100% of those will be falsely negative. So don't get tested the day after you've been exposed. Wait until at least 5 or 6 days have gone by, because you're much more likely to get, a truly accurate test, lower false positive rate. So now I just want to talk a little bit about antibodies. This is a schematic view of an antibody, this Y-shaped thing, and this big green blob is an antigen. The body makes antibodies in response to some sort of antigen, usually an infection, but it could also be an allergen or a toxin. And antibodies have two antigen binding sites. So it's got one here, it's got another one over here. So once you have antibodies that can bind to an antigen and assist the immune system in getting rid of the infection. Sometimes antibodies confer immunity, sometimes they don't. So that's immunology in 30 seconds. So what do antigen tests do? Well, unlike viral RNA test, an antigen test looks for a specific viral protein. So maybe the spike protein, the nucleocapsid protein, and the test chooses an antibody to bind to the target antigen. I'll show you that in a picture in just a second. So then the antigen-antibody complex is usually detected by another antibody that's labeled with some kind of detector, usually a light-giving molecule. And then you use a lab instrument to detect that. So here we have a picture. You have some sort of solid support, and there's an antibody to the desired antigen. So if you have viral antigen present, this antibody here will capture it, and then you add this second antibody that has some kind of fluorescent or radioactive indicator. Fluorescent's a lot safer than radiation. And then the machine can pick up this indicator. So that's how antigen tests work. Currently, there are only 2 antigen tests that have emergency use authorization. The Quidel-Sofia SARS antigen fluorescent immunoassay was released on May 8th. It looks for the nucleocapsid antigen. To buy the Sophia instrument that reads the test, it's about $1,900. The test has a sensitivity of 80% with a 95% confidence interval of 68 to 88%. And its specificity is pretty good. They said 100% with a confidence interval of 96 to 100%. There was a new test that was released on July 2nd, the Beckman-Dixon Veritas system for the rapid detection of SARS-CoV-2. It also looks for the nucleocapsid antigen. Its cost is considerably less. The Veritas instrument only costs about $350. Sensitivity is 84%, specificity again 100%, and the confidence intervals are pretty similar. So both of these antigen tests are rapid tests. They work in about 15 to 20 minutes. Sensitivity is not great, but both tests it's about equal, but they do have high specificity. So now let's talk about antibody tests. These, of course, look for antibodies to SARS-CoV-2. And because it takes a while to develop antibodies, early in the course of infection, the antibody test is not going to be positive. The way these work, it's sort of like an antigen test in reverse. I'll show you the picture in a second. And there are currently now 28 antibody tests with emergency use authorization. Both of those antigen tests I just showed you are CLIA waived, but no current antibody test is CLIA waived. There was one, but the FDA removed their EUA because it wasn't a very good test and was given a lot of bad results. So performance for the current antibody tests that are out is variable, but it's mostly pretty good. Most of them have sensitivities in the mid-90s and specificities in the high 90s. And this is just a picture of the different antibodies that are produced. So here you're in the pre-symptomatic phase. On day 0, you start having symptoms. You know, this is presence of the virus. And somewhere around 1 week, the body starts making IgM, which goes away fairly quickly. IgA follows soon afterwards. It goes away also. IgG is the long-acting antibody, and that starts around 2 weeks after the onset of symptoms and peaks pretty rapidly and then has a long lasting, we don't know yet how long. Looking at the first SARS virus and it mirrors, these antibodies usually are detectable for months and possibly years. So this is how an antibody test basically works. You have some kind of support with an antigen attached rather than an antibody. And if you have antibody in the blood sample, it comes along, it hooks up with this antigen. And then you put another type of antibody in that has an indicator, again, usually a fluorescent indicator, that binds to this antigen-antibody complex, and then the machine reads it and says, yes, it's positive, the antibodies are there. So antibody testing is also known as serology or an immunoassay. It does require a blood sample, and it often requires that you spin down the blood to separate out the plasma or serum. So what's the utility of antibody testing? Well, if you have a positive test, that means that you were infected at some point, most likely. High titers during infection do correlate with severity. People that are really sick tend to have a whole bunch of antibodies. A negative test probably means that you weren't infected, but again, the sensitivity on most of these tests is not 100%. Just in case you're interested, on the FDA website, there's a review of all of these antibody tests and measures of their specificity and sensitivity. So now I'd like to kind of finish up with the Abbott ID Now instrument. I know that this is of great interest to a lot of you because you have one of these instruments. So this is a nucleic acid test. It's really a kind of mini PCR test. It looks for a portion on the RDRP gene. That's the RNA-dependent RNA polymerase gene, in case you're interested. It uses an isothermal process that has been used in the past for detecting RSV, influenza, and group A strep. This isothermal process is what makes it so fast. Rather than the machine taking 2 to 8 hours, you get a result in a few minutes. So you can get a positive test with this because it doesn't have to go through all those heating and cooling cycles. A positive test can sometimes show up in as little as 5 minutes. It takes 13 minutes or thereabouts to completely do the test and to declare it negative. Now, the company, sometime after the machine came out, there was a lot of concern about its accuracy because people were getting false negatives. So the machine was released, or it was given emergency use authorization in late March, March 27th. There was a lot of fanfare when this first came out. Fortunately, the Indian Health Service was able to acquire quite a few of these. And in the Nashville area, I think we had 14 that were distributed to our hospitals and clinics. But pretty soon, by April, and certainly by May, there was a lot in the news about this machine having a high rate of false negatives. And the company came out and said that the swab should be tested dry. Don't put it in saline or viral transport media. Just put the dry swab from the patient directly into the machine. Now, originally, they had claimed that this could detect as few as 125 copies per milliliter, which is comparable with some of the PCR tests. Some of the PCR tests have an even lower limit of detectability. But there was concern that people were sticking it in liquid and it was diluting it out, and the machine couldn't read it then. So there have been a number of published academic studies now. I've reviewed these and picked out 7 that I could find that were actually published and had sensitivity and specificity data. And these have ranged from a low of 54.8% sensitive up to a high of 94% sensitive. And you can see, everywhere in between. Now, what's interesting about this study from New York University, they actually looked at 2 different sensitivities. They looked at sensitivities that were dry swabs versus swabs put into viral transport media. And guess what? They actually got the opposite of what the company recommends. That is, the dry swabs actually did worse than the swabs that were put into viral transport media. So there's some evidence just to kind of mess with us, I guess. None of these studies were exactly the same. This is not comparing apples to apples. They were all done a little differently. The good news is they all showed a very high degree of specificity, like 99 to 100% specific. So Abbott has sponsored a number of studies. These studies have not yet been published. I'm not sure why. It may be because they're still ongoing. They did a study in urgent care clinics in 5 different states that's showing a pretty good sensitivity and specificity. There's an ongoing study in a clinic in Everett, Washington that again had like 91% sensitivity and 100% specificity. And then a study of hospitalized and nursing home patients showed a lower sensitivity and specificity. Now, what's interesting about these studies, the urgent care clinic, the patients in that study were coming in the earliest in their symptoms. The ones in the Everett, Washington clinic were a little further along on average, and the hospitalized and nursing home patients were further into their symptoms. So really, the Abbott is better if used early in the course of the illness. It's much more likely to give you an accurate result. So what are the take-home messages from these studies? Well, the ID now performs well if there's a high viral load, but not so well if the patient has a low viral load. Some of those studies actually did quantification, and so they know that people with higher viral loads, in fact, some of the studies showed that if a person had a moderate to high load, the Abbott was 100% sensitive. So sensitivity is better earlier in the course of the infection when people have a higher viral load in their upper respiratory system. There's some question as to whether maybe it had to do with, maybe it's operator dependent. Maybe some of these studies that showed poor results, maybe the people didn't really know how to use the machine properly. The limit of detection is probably higher than the 125 that was claimed. It's probably more like 1,000 or more copies per milliliter. Specificity is good, so a positive test is useful. But here's my bottom line. If you really think a patient has COVID-19 and they test negative on the ID now, then it would be best to test them with a second test, send out a PCR test to a reference lab. So just to finish up in summary, clinical judgment is still really important. You need to know the case definition and the symptoms for COVID-19. It's very important when taking a history to find out when the patient had the onset of symptoms. I've had 2 patients now with COVID-19 that I took a history from. Both of them could tell me exactly when they started feeling bad. Interestingly, both of them had been out working in their garden and they just suddenly felt very fatigued. So I have decided, based on my experience, that gardening apparently causes COVID-19. That's just a little joke. But it really, people can tell you when they started feeling bad, and it's important to get that information, because if you're going to do a lab test, you need to know which one to do. Lab testing is only a diagnostic aid. You have to really interpret the results with some clinical judgment. The rapid tests, I think, do have their place. They're helpful if they're positive. The rapid tests are not so helpful if they're negative. And antibody testing has limited but some utility in a clinical setting. And that would be in the case of a person who's been sick for probably more than a week. They test negative with PCR, but you really think they have it. You could maybe do an antibody test to see if that's positive. So that's all I had for you today. Thanks very much. And I hope everybody has a great weekend. And I will take any questions that you have now.
Great. Thank you so much for a wonderful presentation. Do we have any questions for Dr. Brown?
I have a quick comment. So, well, thank you, Harry. That was a wonderful presentation. And, even the problem arises not only with the Abbott test that we're using it, but even with the other PCR tests, if they're negative and the patient has clinical symptoms compatible, like you said, you have to use your clinical judgment and treat accordingly or address it. The problem comes that when we don't have a positive test, we cannot start remdesivir because it requires a positive test. And I mean, the only thing we could do if we really think the patient has COVID is give them dexamethasone because that's a drug that's easy to get. But all the rest, convalescent plasma, will require a positive test. And that may change, in the future, because we've had a patient that was COVID positive. I mean, COVID from here to China, but the test was negative, but had ground glass opacities, bilateral. All the other tests were negative, looking for other viruses. And so the problem, but the major problem is like you're seeing a patient in the clinic and they look like COVID and you rule out other things. And we're trying to decide if we label them as COVID-like illness, like we used to do with influenza, but that will not trigger contact tracing. Contact tracing, at least in our system, is triggered by a positive test. And that is an issue that I think we're going to have to resolve unless we get tests that are better, more sensitive than the ones you've mentioned. But even if those tests appear, not everybody's going to have access to them. There's no company that can produce the demand that we need. So I just want to mention that we're still having some problems, but at the end of the day, it's our judgment call that needs to prevail and do the best we can. And thank you for highlighting that.
Well, I got burned. The very first COVID patient I saw had tested negative twice, tested negative on the ID now, tested negative on PCR. her third test on PCR, because there was some degree of suspicion that she might have COVID, came back positive. So, I guess the lesson there is, if you really suspect it, keep testing.
Any other questions for Dr. Brown or Dr. Mara? If not, there is the SurveyMonkey survey link in the chat box. If you will fill that out, it's very short. It'll give us some information about future clinics that we have. Everyone, have a great weekend.